My name is Mark Johnson, and I will be the moderator today. Je m'appelle Mark Johnson.
My name is Mark Johnson. I will be the moderator today.
We will provide an update on the National Advisory Committee on Immunization's guidance for the interchangeability of COVID-19 vaccines. Bienvenue à la conférence de presse.
Welcome to the press conference. We will be giving you an update on the National Advisory Committee on Immunization on interchangeability vaccines.
From Canada's Chief and Deputy Chief Public Health Officers, Drs. Theresa Tam and Howard Njoo. The doctors will be available for questions afterward.
Today, we will hear speeches from Dr. Theresa Tam, Chief Public Health Officer, and Dr. Howard Njoo, Deputy Chief Public Health Officer of Canada. The doctors will be available for questions afterwards.
Please press *1 on your phone.
If you wish to ask a question, please press *1 on your phone.
Note that the content of today's briefing is for attribution.
Today's content is for attribution.
Let's begin.
We will then proceed.
Over to you, Dr. Tam, please.
Thank you. Bonjour à toutes et à tous. Nationally, the steady decline in COVID-19 disease activity continues. The latest 7-day average is now below 2,700 cases reported daily, which is a 70% decrease from the peak of the third wave, with a considerable decline in infection rates. The number of people experiencing severe and critical illness has also declined. The latest 7-day average for the number of COVID-19 being treated in our hospitals each day has dropped 40% since the peak to about 2,600 daily. Of these, on average, under 1,100 were being treated in intensive care units, down 25% since the peak, and average daily deaths are now also down 25% to 39 deaths being reported daily. Although the long months of this pandemic have been difficult, Canadians have worked together to get through the hardest parts, overcome the challenges of the many uncertainties we've encountered, and stepped up to do their part at every turn. This is perhaps no more evident than now, with vaccine uptake increasing in leaps and bounds as supplies have increased and rollout expands. At the same time, Canada's dedicated and diverse health and research professionals have continued to monitor vaccine safety, evaluate effectiveness, and assess the latest evidence on COVID-19 vaccines and vaccination programs in Canada and worldwide. As part of this real-time monitoring and expert review of the latest scientific evidence, Canada's National Advisory Committee on Immunization, or NACI, has worked to quickly adapt its guidance on the use of COVID-19 vaccines in Canada to ensure optimal protection of Canadians at pace with the ever-changing circumstances during this pandemic. As always, NACI recommendations are based on the strength of emerging evidence over top of a strong foundation for many decades of experience with vaccine programs in Canada. NACI's latest guidance, released today, considered a range of factors from safety concerns through vaccine supply to provide recommendations on the safety and effectiveness of the interchangeability of authorized COVID-19 vaccines or mixed vaccine schedules for first and second doses of COVID-19 vaccines. This advice provides provinces and territories with safe and effective options to manage their vaccine programs, specifically advising that people who received a first dose of AstraZeneca COVID vaccine may receive either AstraZeneca COVID vaccine or an mRNA, so Pfizer, BioNTech, or Moderna vaccine for their second dose, unless contraindicated. People who received a first dose of an mRNA vaccine, so that's Pfizer, BioNTech, or Moderna, vaccine should be offered the same mRNA vaccine for their second dose. But if the same mRNA vaccine is not readily available or unknown, another mRNA vaccine can be considered interchangeable and should be offered to complete the vaccine series. In short, the interchangeability of vaccines means that you can receive one vaccine product for your first dose and safely receive a different vaccine for your second dose to complete your 2-dose vaccine series for optimal protection from COVID-19. While NACI continues to recommend that jurisdictions maximize the number of individuals benefiting from the first dose of COVID-19 vaccine by extending the interval between doses up to 4 months, in the context of increasing COVID-19 vaccine supply in Canada, the committee recommended last week that second doses be offered as soon as possible. NACI recommends that priority for second doses should be given to those at highest risk of severe illness and death from COVID-19 disease, after or at the same time as first doses are offered to all remaining eligible populations. NACI continues to closely monitor the effectiveness of extending those intervals and will update recommendations as needed. Canada's regulatory, public health, medical and research professionals remain dedicated to working together to closely monitor vaccine safety and effectiveness while rapidly responding to new evidence to maintain optimal use of vaccines in Canada. As the science and situation evolves, we are committed to providing clear and evidence-informed guidance in order to keep everyone in Canada safe and healthy. Thank you.
Bonjour à toutes et à tous.
Hello, everyone. Nationally, the steady decline in COVID-19 disease activity continues. The latest 7-day average is now below 2,700 cases reported daily, which is a 70% decrease from the peak of the third wave. With the considerable decline in infection rates, the number of people experiencing severe and critical illness has also declined. The latest 7-day average for the number of people with COVID-19 being treated in our hospitals each day has dropped 40% since the peak of about and has reached 2,600 daily. Of these, on average, under 1,100 people were being treated in intensive care units, down 25% since the peak. And the average daily deaths are also down 25% to 39 deaths being reported daily. Although the long months of this pandemic have been difficult, Canadians have worked together to get through the hardest parts, overcome the challenges of the many uncertainties we've encountered, and stepped up to do their part at every turn. This is perhaps no more evident than now, with vaccine uptake increasing in leaps and bounds as supplies have increased and rollout expands. At the same time, Canada's dedicated and diverse health and research professionals have continued to monitor vaccine safety, evaluate effectiveness, and assess the latest evidence on COVID-19 vaccines and vaccination programs in Canada and worldwide. As part of this real-time monitoring and expert review of the latest scientific evidence, Canada's National Advisory Committee on Immunization, NACI, has worked to quickly adapt its guidance on the use of COVID-19 vaccines in Canada to ensure optimal protection of Canadians at pace with the ever-changing circumstances during this pandemic. As always, NACI recommendations are based on the strength of emerging evidence over top of a strong foundation from many decades of experience with vaccine programs in Canada. NACI's latest guidance released today considered a range of factors, from safety concerns through vaccine supply to provide recommendations on the safety and effectiveness of the interchangeability of authorized COVID-19 vaccines or mixed vaccine schedules for first and second doses of COVID-19 vaccines. This advice provides provinces and territories with safe and effective options to manage their vaccine programs, specifically advising that People who received a first dose of the AstraZeneca COVID-19 vaccine may receive either AstraZeneca COVID-19 vaccine or an mRNA, Pfizer BioNTech, or Moderna for their second dose, unless contraindicated. People who received a first dose of an mRNA, Pfizer BioNTech, or Moderna vaccine should be offered the same mRNA vaccine for their second dose, but if the same mRNA vaccine is not readily available or unknown, another mRNA vaccine can be considered interchangeable and should be offered to complete the vaccine series. In short, the interchangeability of vaccines means you can receive one vaccine product for your first dose and safely receive a different vaccine for your second dose to complete your two-dose vaccine series for optimal protection from COVID-19. While NACI continues to recommend that jurisdictions maximize the number of individuals benefiting from the first dose of a COVID-19 vaccine by extending the interval between doses up to 4 months, in the context of increasing COVID-19 vaccine supply in Canada, the committee recommended last week that second doses be offered as soon as possible. NACI recommends that priority for second doses should be given to those at highest risk of severe illness and death from COVID-19 disease after or at the same time as first doses are offered to all remaining eligible populations. NACI continues to closely monitor the effectiveness of extending dose intervals and will update recommendations as needed. Canada's regulatory, public health, medical, and research professionals remain dedicated to working together to closely monitor vaccine safety and effectiveness while rapidly responding to new evidence to maintain optimal use of vaccines in Canada. As the science and situation evolves, we are committed to providing clear and evidence-informed guidance in order to keep everyone in Canada safe and healthy. Thank you.
Merci, Dr. Tam and Dr. Njoo. Thank you.
Thank you.
We will now open the phone line to questions. We ask that you limit yourself to one question and one follow-up. We will be taking your questions in both official languages.
We will take questions and ask you to limit yourselves to one question and one follow-up. You can ask your question in either official language.
Thank you. Merci. Please press star 1 if you have a question. Veuillez appuyer sur étoile 1 pour poser une question. Our first question is from Marika Walsh from the Globe and Mail. Please go ahead. À vous la parole.
Good afternoon. Thanks for taking our questions. Dr. Tam, can you please give a bit more explanation of the efficacy or the immune response from mixing the doses? So if a person got AstraZeneca followed by Pfizer, is their immune response equal to having 2 Pfizer shots, or how do we know that this still gives them sufficient coverage or protection, I should say?
Thank you for that question. First of all, I just want to say that this isn't a new concept. So having multi-dose series in terms of vaccines given by different manufacturers is something that public health have used over time for many other vaccines. So whether it's your flu shots or hepatitis A, or there are many others where over time and when vaccine programs and supplies change, this is not an unusual thing to do. So NACI, in formulated the recommendation, looked at a series of recent studies. So first of all is safety. We'll get to the immune response in a minute, but there's recent studies on safety and one study on the immune response. So there were studies from Germany, from the United Kingdom, as well as from a Spanish trial, reporting that this combination or this mixed schedule of AstraZeneca, followed by Pfizer, for example, is safe, has a good safety profile over a series of different kinds of intervals, 4 weeks, 8 to 12 weeks, for example. And but there is a possibility of increased short-term side effects when using this mixed schedule, such as headaches, fatigue, feeling generally ill, but they are temporary and without complications. And so then if you looked at the actual immune response, the study from the Spanish trial showed that if you measure antibody response in someone who got that second dose, who got AstraZeneca and then had the second dose as Pfizer, they mounted a really robust immune response. So that boosting response that you want to see is very much present. So that's the study in particular that NACI has taken into account. But we do know that there are ongoing studies that we'll be monitoring over the coming weeks and months as well. But that is a very good initial and early sign that this combination has a really robust immune boosting effect.
Follow-up?
Thank you for that. I'm wondering, given what you're saying about the fact that we do have evidence of a robust immune response, why then we still are using AstraZeneca at all? Why is this only a discretionary recommendation and not simply saying, you know, we have the data that shows that mRNA vaccines are sufficient for mixing, so why are we still using AstraZeneca at all, and why? Like, can you explain that?
Yeah, that's a really good question. Of course, this is just mounting data. This is some of the data that we have at the start, and I think NACI deemed that they're sufficient for the recommendation. I think at this point, there are individuals who prefer to get that second dose as the same vaccine series. That's because, of course, the baseline manufacturing indication is to use 2 vaccines on the same dose. And so that option has been retained. But as individuals who are making their choice to get that second dose should look at, of course, all the information in front of them about AstraZeneca, for example, that second dose, what we've seen, of course, one of the elements that NACI took into account when they made a recommendation that is a safety profile and the rare but serious occurrence of this thrombosis and low platelets events after AstraZeneca. What they found at this moment in time, that's not to say this wouldn't change, that the rate of this thrombotic event after the second dose seemed to be lower than after the first dose, but this could increase over time. And I think people need to know that kind of information. Right now, it's 1 in 600,000 people who got that second dose as having that thrombosis event, but that could change. This also needs to be taken into account as people balance the risks and benefits against the epidemiology that's in their local setting as well. But I think it is good news that people now have the choice.
Merci. Prochaine question. Next question, please.
Thank you. Notre prochaine question est de Hélène Buzetti.
Our next question is from Hélène Buzetti. My question is for Dr. Njoo. It's probably an obvious question, but you were giving us figures earlier. There's a reduction of 70% of cases, but only 40% in hospitalization and 25% in hospitalization in ICU. So I'd like to know,
tirer la conclusion
Should we conclude
automatique que ça prouve que les cas sont plus sévères qu'avant?
Cases are more severe than they used to be? Or is there also a possibility that people
ou que maintenant que nos hôpitaux débordent
having less severe disease than before, or now that our hospitals are not as busy, people are being kept in hospital or in ICU longer, whereas in the first wave they might not have had access to that?
Merci pour la question.
Wow. Thank you for the question. That's a good question. I don't have all the probative data in the field, but I would say yes, normally the data on hospitalization and death are late indicators related to infection rates. We also know the epidemiology has evolved because now it is younger people that are being hospitalized than before, and that's something to watch. So it's really difficult to give you an answer to that question and say it's because the hospitals are less overcrowded, but we don't know exactly why. I received some information to the effect that the evolution of the disease means that it lasts longer, a lot of other consequences. So it's very difficult. I think that the lesson to be drawn here is that COVID-19 is still an extremely severe infection at any age. So I think we really have to maintain all the individual precautions and the health measures that public health recommends throughout the population. It's a bit early, but we're already seeing the impact of vaccination because the older people who received even their second dose by now have shown positive numbers. So it's important to continue to deploy the vaccine for all age groups. It's also very important to continue with the public health measures. I know it's not an easy answer to give you right now. Thank you. I have no follow-up. Thank you.
Merci. Prochaine question. Next question, please.
Next question.
Merci. Next question is from Mackenzie Gray from CTV News. Please go ahead. À vous la parole.
Hey, doctors. In the report from NACI, I just wanted to point out that they said that there is, quote, no data currently exists on the interchangeability of COVID-19 mRNA vaccines. If there's no data on it, why is there a recommendation that Pfizer and Moderna can be used interchangeably?
Yes, they're ongoing studies, but they're not published at this point in time. But they are essentially very similar vaccines. They're both mRNA vaccines, and also that they are targeting the similar target, which is the spike protein, in a formation that's actually very similar. So even though maybe the lipid coating is a bit different, but the key aspects of their makeup, as well as that specific spike protein target produced by Pfizer BioNTech and Moderna are essentially very similar. And with that, there's also of course, as I've said, many decades of experience with interchangeability of other vaccines as well. But partly it's because of that very similar nature of the type of vaccine that we're talking about.
Yeah, it's Dr. Njoo. I would just underscore the point that Dr. Tam made, that it's really, of course, we're always looking at gathering more real-world data, but I think where we're also looking at the principles of vaccinology, and as Dr. Tam has stated, the fact that that they're a similar type of vaccine, and we've seen in the past that for different diseases that vaccines from different companies can be used interchangeably with great success in dealing with these other diseases that vaccines have been long used for. That's what we're looking at, and you can see even looking at the dose interval. It was kind of controversial at the beginning. If you look at the manufacturer based on the clinical trial data had a certain interval, but based on the principles of vaccinology, that actually extending the dose interval actually gives you a sort of a longer lasting, better sort of a protection immunity in the long run. I think that's been proven to be true in terms of what we're seeing now with the real world data, with our experience now with COVID-19 vaccines. So I think we're really, on solid ground based on what the experts in vaccinology and immunology have certainly seen with other vaccines, and also what we're also now learning with the new vaccines for COVID-19. Thank you.
Maybe I'll just follow that up. Mackenzie, there are some background in the NACI statement that you can also look at about the general principles of interchangeability. So the vaccine should be authorized with the same indications, similar schedules, same population, recommendations. They contain or produce comparable types of antigen. As I said, this is the S antigen, the spike protein, and they're similar in many ways with their safety profile and their initial immunogenicity and efficacy were actually really pretty similar between those trials. So all of those were taken into account.
Dr. Njoo, you mentioned real-world data, and we've seen a lot of obviously very encouraging real-world data of people getting 2 shots of Pfizer, Moderna, and 2 shots of AstraZeneca as well. We've seen studies out of the UK that have actually pegged that potentially it's 90% against symptomatic disease. Why should we change course when we see that the real-world data with millions of people getting 2 shots has been so good, and the studies that we have out of Spain only have 600 people, and the German study isn't even done yet? Why should we be changing course when the real-world data has shown such success with the vaccines that we currently have?
Yeah, maybe I think just underlying the point that we made with our opening remarks that, obviously the vaccines that were approved were based on sort of a 2-dose schedule. And ideally, they would be a sort of the same vaccine used for both doses. And that's obviously what I think you're stating with the Pfizer BioNTech vaccine, and same with Moderna. And the fact that you may interchange.
Sorry, Dr. Njoo may be having technical difficulties. I would just supplement Dr. Njoo's response, which is we're not, so NACI is not recommending just use them interchangeably, but more that try and use the same vaccine for the mRNA for the second dose. But if you can't find it, or you don't know what someone had, whether it was Pfizer or Moderna for the first dose, then another mRNA vaccine can be considered. But you're correct that some of the real-life data shows that both vaccines and their 2-dose schedule has been very effective. So we'll say just go ahead and swap those 2 doses, try and find the same vaccine, same mRNA vaccine. But if you can't for some reason, then they consider them interchangeable.
Merci, thank you. Do we have you back, Dr. Njoo? Non, pas encore. Okay. Allez avec la prochaine question. Next question, please.
Thank you. Our next question is from Mia Robson from the Canadian Press. Please go ahead. À vous la parole.
Hi, Dr. Tam. What would you say to Canadians who are looking at all of this data and feeling like every time a new recommendation comes, we're sort of rolling the dice on the limited information that we have? And we're getting to the point now where the people who aren't vaccinated are maybe the ones who we have to convince. So what do you say to them who look at this and just wonder, well, how do we know that any of this is safe if it's based on such small numbers?
Yeah, so thank you for that question. First of all, I think it's really very encouraging, the vaccine uptake at this point in time. So I am very encouraged by the vaccine uptake. and that the vast majority of Canadians are following public health advice. And even though, I have to say, over time, some of it has been difficult to understand, they followed along with the public health authorities. They've rolled up their sleeves. And they, in fact, have been waiting for this recommendation with eagerness. And that especially those who received their first dose as AstraZeneca. And so I think, much as with the other recommendations, I have a lot of confidence in the work of both Health Canada regulatory authorities, but also in the National Advisory Committee on Immunization. They should be reassured that, as I've said in some of my preceding responses, that this is a pandemic. We will get real life data, and it is great that we do. But which means that the committee has to update its recommendations on an ongoing basis. But on top of the real life data, which is very important, and I've just told people what they were, particularly safety, but this good immune boosting effect of that second dose that's different, the mRNA following AstraZeneca, are those general immunological and vaccine knowledge that have been built over decades of vaccine programmatic use and the immunology that goes with it. And so I think from that perspective, Canadians should be reassured that we're here to be transparent and give them the information as it becomes available. It is not easy for people, we understand that. But we will strive to provide this information as clearly as we can. But we will get more data. And I think as we've seen, as Dr. Njoo has said, when NACI recommended the initial interval recommendation, people were understandably had lots of questions. But we know that we have to monitor this on an ongoing basis. So I think one commitment that the public health community and our experts have committed to is just ongoing updating and monitoring as we have the information, and we'll communicate that.
Thanks. I'm also wondering if you could talk about why we haven't provided more advice to go faster to second doses, and what information we have about 1 dose versus 2 dose against the variants of concern that are circulating in Canada.
Yes, it's very important for people to get 2 doses of a 2-dose schedule. That is absolutely vital for people to remember that. So always go back for your second dose. So for that interval, we've been monitoring the evidence, and that first dose showing very good effectiveness over time. In fact, last Friday, I presented a graphic that showed that, in fact, the number of people who got infected after receiving a first dose, 14 days after receiving that first dose, is actually a very small number, and even smaller if you looked at the number, but smaller numbers of people who receive the second dose and see what happens to them. Very few of them get infected. Having said that, really you need that 2 dose for maximizing your protection and for the duration or the durability of that immune response, which is still being monitored at the moment. When it comes to the variants, in particular, the B117 variant and the B1617.2 variant, which are the more predominating variants in Canada, but also especially B117, but also globally. These are the 2 that we're watching at the moment. They are more transmissible and they spread. But in general, 2 doses of vaccine are very good for covering them. But 1 dose of vaccine showed less vaccine effectiveness in a study that came from the United Kingdom. So again, if variants are circulating, it's very important to get the second dose. Then, well, what is the optimal interval? I think we know, in fact, that based on, again, basic immunological knowledge on vaccines, but now real-world data, again, perhaps for the data coming from the UK showing the Pfizer shot, for example, if you stretch the interval, even for the more senior populations, the immune response is really good, and in fact is probably better after a more extended interval. So what do we do with all that information? Well, I think right now, public health authorities are now compressing that second dose now that vaccine is more available. They will not be going to the 16 weeks. They'll be compressing down. Many of them are compressing that interval down to about 8 weeks, which sets a bit of a balance between the fact that you might want the second dose as quickly as possible, but also to not perhaps go down too far and not being to take advantage of the potential augmentation of maturation of that immune response at a longer interval. So it's a bit of a balancing act, and you're going to see provinces come out with how they are scheduling and second dose. Yesterday, I actually read that in Saskatchewan for the first time, yesterday they had more doses given for second doses than they do for first. So you're going to begin to see that acceleration of that second dose in the days ahead.
Dr. Tam, it's Dr. Njoo. Just want to make sure I reconnect. I apologize. I lost my internet connection, so I'll have to talk to my company about that, internet company. The only thing I would also add to maybe what Dr. Tam said about the variants, and I apologize if I've missed something that was already said, is that one of the, I think, the issues that the provinces and territories are also looking at is that we obviously want to make sure that everyone gets their 2 doses, and we want to improve vaccine coverage, but you can't just look at it for, let's say, jurisdiction as a whole. I think we're also very live to the issue that there are maybe pockets or maybe certain communities in which, there's maybe a more sort of under-vaccinated individuals compared to the population as a whole. So that's also very important in terms of dealing with variants, but also COVID-19 in general. So I think that's one of the things that we're going to also drill down to. I think obviously our colleagues in the provinces and territories, and looking at pockets, looking at maybe a certain key subpopulations, what might be driving why there may be under-vaccinated, is it vaccine hesitancy, et cetera, and so on, and trying to drive and deal with that as well, so that overall for Canada, we will hit our targets in terms of the vast majority of the population receiving their 2 doses. So I'll leave it at that. Thank you.
Thank you. Next question, please. Prochaine question, s'il vous plaît.
Thank you. Our next question is from Abigail Beyman from the Global News. Please go ahead.
Hi there. Sorry, having trouble getting off mute. Thanks for taking my question. I understand that NACI has consistently recommended that a vaccine series be completed with the same vaccine product when possible. So I'm just wondering, in the case of this specific AstraZeneca discretionary recommendation, does the advice about AstraZeneca replace or become more important than that earlier recommendation to complete with the same product?
Yes, one of the, it's Theresa Tam, one of the key drivers of considering this recommendation is the observation, of course, of the rare but serious side effect of the vaccine-induced thrombosis with low platelets. But they took into account the other observations of adverse effects, mild but more increased frequency, and with this mixed dose schedule, as well as what we just went through in terms of safety and immune response study that is available. So really, I think NACI is providing an option of moving away from using the same vaccine for that series. That is generally the principle to go along with, is to use the same vaccine to complete that schedule. But given that observation of that rare but serious adverse event, as well as these safety and immune boosting effect of that mixed vaccine schedule, this recommendation has been made. But again, recommendations undergo evolution over time, and this is the next stage of the increased understanding of our vaccines.
Thank you. I'm also wondering.
Yeah, I was just going to add to that. It's a good question, and certainly to repeat what Dr. Tam said, that normally the recommendation about if you start a vaccine series with one type of vaccine, you should complete that, and certainly that's the principle. In the case of AstraZeneca, we're all aware of this safety signal, this rare event. It's rare, but if it does occur, it's serious. And so I think based on the evolution of the science and the data we have, the recommendation now is to basically give enough information so that people at the end of the day who have received AstraZeneca as their first dose can make an informed decision. Everyone will have the information, and some people, based on their risk tolerance, how they feel about the risk of this rare event, with all the other considerations, may feel more comfortable. Yes, I started with AstraZeneca, and I will complete my series of shots with AstraZeneca. There are millions of people around the world that have received the 2 doses of AstraZeneca, and that's fine. Others who may look at the data and this rare safety, signal with maybe a different view and not want to maybe quote tolerate that risk. Now there is that option, because looking at the data and the principles of vaccinology and so on, that there is now this recommendation from NACI, and certainly the provinces and territories are taking that into account in terms of how they're offering that second dose for those individuals who have received that first dose being AstraZeneca. Thank you.
Thank you, and sorry for interrupting you, Dr. Njoo. My follow-up question, I'm wondering if any modeling or thoughts have been done about how this will actually affect the vaccine rollout. Do you expect that any AstraZeneca doses will end up unused or having to be tossed because people will move over to mRNA? Is there any sort of planning in the works for the real-world impacts of NACI's recommendations?
Go ahead, Theresa.
Yeah, no, I think that's a really good question. We don't want to, of course, leave any vaccine doses unused, and that has to be minimized. So I think we will have to watch very closely what happens after this recommendation and the provincial programmatic changes, and monitor the actual uptake of AstraZeneca over time. I think what we will stress is there's enough vaccines from both for people to receive either the second dose as AstraZeneca or as mRNA. So that is not an issue, but what you're saying is really important. We don't want to be ordering vaccines if we're not using it, but that can only be ascertained, I think, in a more granular way when we see what the uptake looks like in the coming days.
Yeah, Dr. The reason I was going to jump in is because obviously I also do sort of the vaccine technical briefings with Brigadier General Brody, and certainly her and her team are working very closely with their counterparts in the provinces and territories. The principle we started with is that everyone who received the first dose of AstraZeneca, and that's about 2.1 million Canadians, certainly should have the option to be offered that second dose. And certainly that was the initial planning assumption. But based on what's happening in real time with the provincial territorial programs, looking at sort of the orders to be placed and so on, that obviously is something that at a very granular level, Brigadier General Brody is continuing to work with her counterparts to get a further precision, and we'll adjust in terms of obviously what the provinces and territories will be requesting in terms of their final order, obviously based on, as you say, the demand for the AstraZeneca vaccine for those individuals who may want to receive that as their second dose. And of course, we have lots of mRNA vaccine, and now with the NACI recommendation, are able to offer that as another option for those individuals. Thank you.
Next question, please. Prochaine question.
Thank you. Notre prochaine question est de Olivier Lefebvre.
Our next question is from Olivier Lefebvre of Radio Canada. Please go ahead.
Oui, bonjour.
Yes, hello.
J'aimerais poursuivre sur
I'd like
la
to
même
continue
question, mais cette fois en
with the
français.
same question
Donc,
in
vous
French.
croyez que cette recommandation
Do you believe that this recommendation
qu'on n'utilise pas, qu'on
could
gaspille
mean that
des doses de vaccin
doses of vaccine are
AstraZeneca
wasted?
au Canada?
AstraZeneca specifically.
Merci pour la question.
Thank you for the question. This is Dr. Njoo.
Oui, c'est un enjeu actuel.
This is an issue right now. What's going on now is that
Brigadier General Brody
Brigadier General Brody is working closely with his provincial and territorial counterparts because this is a question of demand too. All the provinces and territories are aware of how many people in their jurisdiction have already received the first dose of AstraZeneca. In total, for all of Canada, it's 2.1 million people have received AstraZeneca as a first dose. So for the second dose, we've started to plan. We have to be prepared to offer a second AstraZeneca dose to everyone who received the first dose of that vaccine. But given demand and what's going on right now in the provinces and territories, and with the recommendations that another option, another choice can be offered to those who got an AstraZeneca dose the first time, Brigadier General Brody continues to work closely with his counterparts and will probably adjust the deliveries of AstraZeneca vaccines to the provinces and territories because, yes, we have the same principle. We don't want to waste vaccines, as Dr. Tam and others have noted. We want to make sure that the supply of vaccines is really what we need here in Canada. So this is something we continue to work on with the provinces and territories right now. Thank you. Follow-up question?
Justement, le gros de vos recommandations, vous annoncez en fait
the main recommendation you have about the interchangeability of vaccine. Why is this happening now? Why didn't it happen earlier? Because you were saying this practice has been in course for a long time. You mentioned that. Why is this happening now? Is this because it's felt there's some emergency against in the race against the Indian variant? Yes, that's a good question. Yes, the principle of interchangeability of vaccines for other contagious diseases is well established. And for sure, with COVID-19, we continue to learn from experiences in the real world. As NACI has said in its statement, they've analyzed probative data from 3 experiences in other countries. We're still waiting for more data, and it's always a matter of striking a balance because if you wait for other probative data, it may be too late. You have to make a decision at some point. And so I think this is the right time, given the experience and probative data. We see what's going on right now in many countries, 7 countries, I believe, have offered a second dose of an mRNA vaccine for people who already received AstraZeneca first. So we're looking at what's going on in these countries that changed their policies. I think that Canada is in a good position. We have probative data, we have experience from other countries, and we're using vaccinology and immunology principles that are well established. There's a practical reason too, because the first group that got AstraZeneca have gotten it about 12 weeks ago. So now's the time to give recommendations to the provinces and territories so that they can continue their program. It's a practical issue.
Question is from Thunder McCharles from the Toronto Star. Please go ahead. À vous la parole.
Hello, Dr. Tam. I haven't had a chance to read through the whole document, but I just wonder if you could clarify. So as I understand it, then the mRNA vaccines can follow AstraZeneca and another mRNA can follow another mRNA. But why is the reverse not true? Why couldn't an mRNA vaccine be followed by an AstraZeneca dose if someone was so inclined?
I think there are studies that will come out looking at that combination, particularly from the United Kingdom. At the moment, the practical question about the interchangeability of the second dose is also driven by the observation of the rare but serious side effect of thrombosis and thrombotic events with low platelets after AstraZeneca. So if it wasn't for that, then probably one would progress with giving the same dose as the second dose. That is the underlying authorization for these vaccines. But because of that observation, the whole world was very interested in the option for that second dose, and many countries have gone ahead already, and like many countries in Europe, for example, have already gone ahead with that mixed vaccine schedule. So that was the obviously the key piece of recommendation coming from the committee. For the mRNA vaccines, I think as some of your colleagues have pointed out, performed extremely well in terms of clinical trials and real world effectiveness with 2 doses of the same vaccine. So and we should be following the indications for using the same vaccine. But if for whatever extraordinary circumstances you don't have that, or you don't have the same vaccine for the second dose because of supply, or you showed up for practical reasons, or you don't know what you had the first dose, maybe you got it from another country, who knows? But then another mRNA vaccine can be considered to just complete the series. The key is to get 2 doses.
Okay, thanks. The other question I have is Health Canada's media relations couldn't answer this question and suggested I ask it at this news conference, even though it's not quite on topic, but perhaps you can shed some light on this. The guidance that has been issued in terms of how various sectors should respond and look at reopening and whatnot. I'll deal with sectors and employers and industries, but I'm wondering if you have or will, or do you intend to give specific guidance to individuals, or will you leave that solely to provinces and territories? And by that, I'm asking things like somebody who has a first vaccine, what can they do? Someone who is fully vaccinated, what can or should they do if, for example, they come into contact with a positive COVID person, they have a direct contact? Should a fully vaccinated person be isolating now for, presuming their immunity response has been prompted? Do they now need to isolate? When can we expect to see that kind of specific guidance from the federal government, or will we? Maybe that's completely up to the provinces.
Yes, thank you for the question. And those are some of the key shifts in policies that the provinces are examining right now. For example, if you're fully vaccinated and you were under an exposure setting, would you be considered as low risk, or would you a low risk contact, or would you be required to quarantine? And some jurisdictions have already shifted on that front, and they are timing it a bit differently, partly not just because of the vaccine rollout, but because of the epidemiology that's taking place. Some of them are still in the very much the height of the third wave, and others are beginning to turn their attention to these shifts, because the risk that you might take of a fully vaccinated person still having a small chance of carrying the virus or transmitting it can be absorbed, can be tolerated more if your epidemiology is well and your outbreak's well under control, and you've got a lot more people vaccinated. So we are taking much more of a community-based approach in Canada, where we know that vaccines are very effective, but not everybody can get the vaccine, or not everybody who is even fully vaccinated. There are a few who can't be protected, or you can maybe immunocompromised. So the idea is that we really need to get the community-based vaccine levels up. Having said that, though, there will be very specific protocols at the more local level that would begin to shift as a result. For example, in long-term care and visitors, in healthcare workers who may no longer have to quarantine after an exposure because they're fully vaccinated. So that is actually going along in the provinces as well. Once we get to the bottom of the third wave and more Canadians vaccinated, I do think that it is helpful for people to have more of a individual risk assessment of their particular situation. Not only because they're vaccinated, but their own personal health conditions, what kind of risk they are walking into in terms of the context of their exposure. Are you going into a giant party where you have no idea who is there and who got vaccinated? Or are you actually getting together with a few people in a social bubble where you can absolutely be certain that the other people have had the vaccine? They're very different contexts. And I do think that having a bit more tools for people to work through those risk assessments are important. I mean, we did say that before, even for social bubbles in the past. They're very local level recommendations based on the epidemiology, but also the obvious settings where it's more risky. The sort of closed, crowded environment. So even if you're vaccinated and you don't know who's there, who's vaccinated or not, that gives you a very different individual risk assessment. So we're looking forward to having more of those granular discussions. But the bottom line is we gave some guidance, if you like, through modeling on the levels of community-based vaccine coverage that is needed for the safe lifting of measures.
Thank you. Merci. That will be all for today's press conference. Thank you for your participation. Any additional questions can be directed to Media Relations at the Public Health Agency of Canada. La conférence de presse est maintenant terminée.
The press conference is now over. We thank you for your participation. If you have more questions, please don't hesitate to communicate with the Media Office as the Public Health Agency of Canada. Thank you.
Thank you. Merci. The conference has now ended. Please disconnect your lines at this time, and we thank you for your participation. La conférence est maintenant terminée. Veuillez s'il vous plaît raccrocher votre ligne et merci.